Good afternoon, everyone. My name is Dr. Philip. I'm a general surgery senior resident at TD Medical College, Alappuzha. So today we'll be discussing a seemingly simple but a very interesting and very clinically very useful topic, that is shock. So we'll be discussing it under three topics, that is mainly the definition of shock, then about the pathophysiology of shock, then about the classification of shock. These will be the three topics under which we'll be dealing the topic. Okay, coming to the definition. Basically, what is shock? Shock is a systemic state of low tissue perfusion that is inadequate for normal cellular respiration. Basically, it implies that it is a state of systemic hypotension. Okay, what is the pathophysiology? What is causing? If at all the system is getting hypoperfused, what is the issue which is happening? For that, we need to know the pathophysiology. Pathophysiology can be discussed under three headings. Okay, it can happen under the cellular level, what is happening, the microvascular level, what is happening, also in the systemic level, what is happening, need to be dealt with to understand what is happening in the different types of shock. So, coming to the cellular level. As we know, we have learned in basic biochemistry that glucose is getting utilized in the cell to be converted to pyruvate by the glycolytic pathway. Then after that, it is taken up into the aerobic or anaerobic respiration. So, in a state of decreased perfusion, that is in a state of tissue hypoperfusion, where the oxygen supply is getting hindered, what happens? The pyruvate is entering into the anaerobic pathway. So it gets converted into lactate. Basically, what is lactate? Lactate is an acid. So what accumulates when there is more of anaerobic respiration? Anaerobic respiration leads to accumulation of lactic acid, and that can lead to metabolic acidosis at the tissue, at the cellular level. Metabolic acidosis can happen. This is the basic thing which happens when there is tissue hypoperfusion at a cellular level. What are the other things which can happen? On further worsening, these cells, the glucose supply gets depleted. So after the glucose supply gets depleted, what happens? The cell is deprived of glucose, and the cell membrane channels, sodium, potassium, ATPase, and all such helping channels get depleted, and the cell goes into a state of autodigestion. Autodigestion and release of intracellular contents. When it comes to intracellular contents, the most dreadful thing is the electrolyte which is present in abundance in the intracellular compartment, potassium. Potassium gets released out of the cell. That can lead to hyperkalemia in the long term. This is the basic, these are the two things which happen at the cellular level when it comes to shock. Now coming to the microvascular level. Already we told, at the cellular level there is tissue ischemia is happening. Basically, hypoperfusion means there is reduced supply means tissue ischemia. So, when it comes to the microvascular level, how does it affect our body? So, whenever there is hypoperfusion, the microvascular tissues are devoid of oxygen supply. So, what happens? Basically, our body starts activating the complement pathways. What happens if the complement pathways are getting involved? When the complement pathways are getting activated, what happens is it starts releasing cytokines, and also oxygen-free radicals are getting released. So what happens when the oxygen-free radicals and cytokines are getting released? I'll just write it down for you to understand. That is whenever there is tissue ischemia, there will be complement activation. So whenever there is complement activation, what happens? Complement activation leads to cytokine release. Cytokines are getting released, and also oxygen-free radicals are getting released. Free radicals. Both of these contribute to what happens when these two can lead at a microvascular level. What happens? What are these two doing? These two will contribute to endothelial injury. Microvascular endothelial injury is happening due to tissue ischemia. So what happens if there is endothelial injury? The capillaries become leaky. Leaky capillaries lead to extravasation of intravascular contents, and that can lead to tissue edema, and also at the same time it can also worsen the autodigestion of cells, leading to further tissue damage. Then the third heading under pathophysiology, we need to know what is happening at the systemic level. In the systemic level, we need to study about 4 systems in basic. Systemic level, what happens? First system is known cardiovascular, CVS. Second, respiratory system. Third is the renal system. And fourth is the endocrine system, which we need to know about when it comes to shock. So, whenever there is tissue hypotension, what happens? Basically, hypotension means there is a decreased circulatory volume. If at all, the decreased circulatory volume, not in every case, most of the cases will be dealt with decreased circulatory volume. That is, there will be tissue hypotension. So, when it comes to serious level, when we are talking about the cardiovascular system, whenever there is a decreased preload and afterload, that's whenever there is a total decrease in the circulating volume, what happens? The baroreceptors which sense these changes get activated. Baroreceptors are getting activated. Baroreceptors, what do these do? Baroreceptors, they activate our sympathetic system. Sympathetic system is getting activated. So what happens if the sympathetic system is getting activated? As we know, what contributes to BP? Blood pressure. Blood pressure is how do you measure? Basically, blood pressure is our cardiac output into systemic vascular resistance. And to break it further down, what is cardiac output? Cardiac output is basically stroke volume into heart rate. So, from this we can understand that BP is systemic stroke volume into heart rate into systemic vascular resistance. So, whenever the tissue is going into hypotension, what is the change which we expect from the tissue? Or what is the change which the sympathetic stimulation can help you with? That the heart rate can be increased. Heart rate will increase. Also, the systemic vascular resistance, which contributes to the afterload, will also increase to compensate for the fallen BP. This is what happens at the cardiovascular level when it comes to pathophysiology at the systemic level. Then further on, we will also just have a brief discussion about what happens at the respiratory system level. Respiratory system. What happens in the respiratory system? As I told, shock, tissue hypoperfusion, hypoxia, metabolic acidosis. Whenever our body is in a state of metabolic acidosis, how do we compensate for this metabolic acidosis in our body? Tissue, our body starts to breathe more. Our minute ventilation increases, our respiratory rate increases. What happens if our respiratory rate increases? The metabolic acidosis can be compensated by a respiratory alkalosis by increasing the minute ventilation. Respiratory rate is increased, minute ventilation, just note it down, minute ventilation is increased. Okay, that is how our respiratory system contributes to respond in a systemic level to shock. Then the third system which I told about is renal system. As we know, whenever the sympathetic system is getting stimulated by the at a cardiovascular level, when the sympathetic system is getting stimulated by the baroreceptors, what happens? The sympathetic system as a whole is getting involved. So the RAS system, which acts at the level of renal system, gets activated. The RAS system is activated. Basically, everyone would have studied in physiology, basic physiology. RAS system is renin, angiotensin, aldosterone. Renin is stimulated, aldosterone, angiotensin levels are increased. I hope you understand, and this is angiotensin and this is aldosterone levels are increased. What happens when these both are increased? Angiotensin and aldosterone combined, they increase the sodium and water intake. It absorbs more of sodium and water, and also aldosterone. What does basically aldosterone do? That is a small mistake. Basically, angiotensin increases the systemic vascular resistance, and aldosterone increases the sodium and water absorption from our renal tubules. They contribute to more of, as I told before, as per when a BP falls, we need an increase in the systemic vascular resistance, and also along with sodium and water intake, our circulatory volume levels are also tried to be increased by our renal system. There is one more system which is also involved in the systemic level. Just a brief discussion about that. At the endocrine level, as we already told, we have these aldosterone mechanism. RAS system is activated. Along with that, we also have something known as ADH, antidiuretic hormone. What is ADH? What is basically ADH? Antidiuretic hormone. That acts against the diuretic mechanism of the kidney. So basically what does it do? It increases systemic vascular resistance. Along with that, it has a water resorption capacity from the distal collecting duct. So distal collecting duct, water reabsorption. Distal collecting duct, I have written as CD, water reabsorption is getting done. So these are the four systems. Pathophysiology happening in the four system levels which can contribute and compensate for the things, for the tissue hypoperfusion which is happening in shock. So we have discussed about two of our topics, then we'll move on to the third topic, the most important topic which we need to deal with. That is the classification of shock. Classification. Most of you might be aware about the basic classification. The thing which we need to understand is that however we classify shock, we need to know that every type of shock is a state of systemic hypoperfusion. So, the basic understanding when it comes to clinical practice is a patient, when presenting with shock, can have a coexisting multiple types of shock. That is, a patient with hypovolemic shock can also have a septic shock, or these things can coexist depending on the clinical scenario. So these are not things which we blindly mug up from these headings. We need to understand what is happening and we need to correlate clinically to understand what is happening in the human body. Just for basic definition's sake, classification, the shock is classified into 5 types. As per the New Bailey, we are writing it into 5 types. The first one is hypovolemic shock, the most common type. Hypovolemic shock is the most common type. Second, cardiogenic shock. Cardiogenic shock. Third one, distributive shock. Fourth, we have obstructive shock. Then fifth, this is the endocrine shock. At an undergraduate level, when we are discussing about shock, the basic understanding is that we need to identify what type of shock is being mentioned whenever asked about a question, or whenever you see a case in an emergency. We need to understand what is happening, whichever system, what is the type of shock which is happening in that patient. We need to know about that. So I think I'll just start with explanation by giving a clinical scenario so that you guys can correlate how to identify such cases in new clinical scenarios. So we'll start with the most common type of shock, that is the hypovolemic shock. Before discussing about all these type of shock, I also like to mention about, there is a chart in Bailey giving you 5 cardiovascular and metabolic characteristics of shock, which is used to differentiate 4 types of shocks, that is hypovolemic, cardiogenic, distributive and obstructive. These 4 headings need to be dealt. I'll just write it down, and then in the end, after discussing all these types of shock, we'll compare and correlate all these 4 types of shocks. So when it comes to shock, what are the things which we need to know about? What are the cardiovascular and metabolic characteristics of shock which is important? The first thing is cardiac output. First heading is cardiac output. This we'll discuss with comparing with all the other types of shock. First of all, I'll write all these headings down. Second thing which we need is peripheral vascular resistance. Peripheral vascular resistance is second topic. Third one, venous pressure. This is measured by CVP or central venous pressure. Fourth one, mixed venous saturation. Mixed venous saturation. That when we discuss, I'll tell you more about it. Then the fifth one is base deficit. These are the 5 characteristics by which we have classified our 4 types of shock. That is hypovolemic, cardiogenic, distributive and obstructive shock into. Depending on all these 5 characteristics, we can differentiate all these 4 types. Endocrine, I'll discuss later. I'll tell you more why is endocrine not included, because it is a combination of different types of shock. So basically, what is hypovolemic shock? In hypovolemic shock, it can be the most commonly seen hypovolemic shock is hemorrhagic shock. But that does not imply that the only hypovolemic shock is hemorrhagic shock. And hypovolemic shock is basically divided into hemorrhagic shock, And second is non-hemorrhagic shock. Non-hemorrhagic shock. I just written a short form, non-hemorrhagic shock. So what happens in hemorrhagic shock? It is understood that following a blunt trauma abdomen, that is for a young male or female who presents following a high velocity road traffic accident with sustained injury to the abdomen. When such a patient presents to you in a state of hemodynamic instability. What does hemodynamic instability mean? That is, the pulse rate is elevated, that the patient is having tachycardia, BP is decreased, hypotensive patient. We need to suspect that a hemodynamically stable patient with a blunt trauma to the abdomen, that patient is very likely to have an injury. Intra-abdominal visceral organ injury might be there, causing the blood loss, which should be addressed at the earliest. That is a significant entity when it comes to surgical practice, and hemorrhagic shock is a very important entity which needs to be managed as a very critical case in the emergency setting. Just a basic understanding. I'll just mention about the non-hemorrhagic shocks also. What are the non-hemorrhagic shock which you get? Examples of non-hemorrhagic shock which you can see. Basically, non-hemorrhagic hypovolemia means either the intake of fluid is less or the outflow of fluid. That is, intake when it comes to malnutrition or examples of like that, or when it comes to outflow. That is, if there is there is significant diarrhea, significant vomiting, that the patient is not able to tolerate orals. If the patient is not at all having an intake of orals, but the patient is having continuous diarrhea, continuous vomiting, that can lead to hypovolemic shock. What are the other things which can also fall under non-hemorrhagic shock is, that is, basically I told about the intake and exit, intake and outflow. Along with that, there can also be third space loss. I'll just write down the headings, that is, basic vomiting, significant vomiting, diarrhea. What is the second thing which I told? Decreased intake. That is old age, malnourished. What is the next thing which we need to know? That is very important. Third space loss. Third space loss is significant. What happens in third space loss? I'll just give you two examples to understand about third space loss. The two examples are mainly, we can see these kind of issues in burns, and also burns. Initially, when a patient presents with significant burns, that's almost 50 to 60% burns, that patient can have severe dehydration at initial presentation. That's why we have a Parkland, modified Parkland formula, giving them significant fluid to replenish for the fluid loss. That is the third space loss which is occurring in burns. Also, there's in pancreatitis. In a case of severe acute pancreatitis also, the patient presents initially, that is a young patient with a history of binge alcohol intake, when presenting with an epigastric pain. If he presents with an epigastric pain, and you notice that the cardiac markers, ECG, everything is normal, and the amylase lipase levels are elevated, then we arrive at a diagnosis that the patient is having an acute episode of pancreatitis with history of binge alcohol, means ethanol-related acute pancreatitis. In such cases, if the patient presents with tachycardia and hypotension, we should always suspect hypovolemic shock. That is a case of hypovolemic shock, can be associated with pancreatitis also. So these are the examples which come under non-hemorrhagic shock. Hemorrhagic shock and management should be dealt with in more detail. We will discuss it later. So basically, what are the scenarios which you can see? I told hypovolemic shock. What is the first thing which you check? What is the first thing which you need to know? That is, hypovolemic shock is basically a decreased circulating volume of blood in the human body due to multiple causes. The causes can be hemorrhagic or non-hemorrhagic. That's how we approach it, hypovolemic shock. What is the next thing? What is the next type of shock? I told cardiogenic shock. As you know, cardiogenic shock is more dealt by cardiology or medicine departments. What happens? I'll just give a small clinical scenario just for you to identify what happens. A young or a middle-aged, I'll give a 40-year-old patient with hypertension on irregular medications, present with acute onset chest pain, radiating to the arm, and on taking an ECG, you notice 40-year-old hypertensive. This is a clinical scenario, hypertensive, not on regular medications, presents with ECG changes showing an ST elevation in 2-3, just an example, 2-3 AVF. ST elevation 2-3 AVF is suggestive of an inferior wall and If such a patient presents with hypotension and tachycardia, that should be dealt. That's the case of what is happening there. That patient is having an ST elevation, STEMI, ST elevation, myocardial infarction is happening in such a patient. That is a case of inferior wall MI. If at all, it is involving the ST elevation 2-3 AVF. In such a case, a patient presents with MI along with hypotension. That is a case of cardiogenic shock. That depending on the scenario, as I told, inferior wall MI, you can give IV fluids. You can start with IV fluids, and depending on the need, inotropes and supportive medication should be taken. Or else there are also other types of MI. Depending on the need, we need to identify the correct type of MI, and emergency intervention need to be dealt with. This is a case of cardiogenic shock. Then the third type of shock, that is obstructive shock. The basic examples which you need to know in obstructive shock is what causes obstructive shock. If someone asks you about what are the examples which can cause obstructive shock in a surgical setting, we need to know about 3 headings basically. That is, examples are cardiac tamponade, second one is tension pneumothorax, third one is pulmonary embolism. You need to know about these 3 headings significant enough. Even in the recent NEET super specialty exam, for our exam, a question was, a clinical scenario was given of pulmonary embolism and the type of shock involved was asked. We might miss simple details. Whenever we study more and more, we miss out the simple details. So you need to know basically what are the types of obstructive shock. So you shouldn't miss out the basic headings, the basic types of shock which can be seen, basic systemic causes which can lead to obstructive shock. That is cardiac tamponade, tension pneumothorax, and pulmonary embolism. I'll just give a clinical scenario just for you to understand that this is a case of obstructive shock. I'll give you an example. There is a 40-year-old patient sustained a high velocity injury following a road traffic accident. Patient presents to the casualty. On examination, you see that the patient is conscious. I'll just write the clinical scenario. A 40-year-old male, RPA. On clinical examination, you notice that his GCS is full. He is having a distress. His hemodynamic levels are not stable. You notice that he is having tachycardia. Pulse rate is elevated. You notice that his BP is less. And on further clinical examination, you notice that the patient's heart sounds are reduced. And you notice that his JVP is elevated. A typical clinical scenario, that is hypotension, muffled heart sounds, raised JVP. Following in case of part A, what do you suspect? This is the Beck's triad. Beck's triad is suggestive of cardiac tamponade. What happens in cardiac tamponade? If at all the patient presents with cardiac tamponade, it needs to be dealt with emergency pericardiocentesis if the patient is in shock. That is a very significant and a deadly, life-threatening complication, life-threatening disease following a disease, that is a condition following a significant road traffic accident that the patient, if not intervened at the right time, can go into death. So emergency pericardiocentesis is the treatment that can be done. As a topic, cardiac tamponade can be dealt in a different scenario. I'll just explain that these are the clinical scenarios where you can expect an obstructive type of shock. So what happens in this kind of shock? That we'll deal with on the physical characteristics I told, the five characteristics that we'll deal with at the end. Okay. So along with that, I'll give you another example also just to know about it. In the same scenario, if the 40-year-old male patient is presenting with a high velocity injury and you notice that the score is full, the patient is having BP decrease, but heart sounds are appearing normal. The heart sounds are normal with raised JVP. And you notice that the tachycardia and the patient is hypotensive, and you notice that air entry is decreased in the left side. That these three criteria do not meet the Beck's triad, but rather it is a case of tension pneumothorax where the air entry is decreased on a particular side of the chest, which needs to be intervened by an emergency thoracostomy, or else the patient will also go into death. This is also a case of obstructive shock. Why do we call this obstructive shock? Here what happens basically, how does the patient go into hypotension? Here, whenever there is a large mass, whenever there is a tension pneumothorax or a cardiac tamponade, these things are causing a pressure on the inflow mechanism of the heart. That is the superior vena cava or inferior vena cava is getting compressed. So what happens? The inflow preload is getting decreased. So to compensate for that, the system is going into increased systemic vascular resistance. Peripheral vascular resistance will increase, but the preload which is decreased due to the compression should be treated at the earliest for the condition to improve, or else the patient can go into death. Similar scenario is pulmonary embolism, which is also a cause of obstructive shock. Then talking about the fourth type, that is the distributive shock. This is something which needs to be dealt separately, because unlike the usual scenarios seen in hypovolemic, cardiogenic and obstructive shock, this patient who presents with distributive shock, as in the examples are septic shock. Second example is anaphylactic shock. Third example is neurogenic shock. What happens in all this scenario? What is the difference? What is the difference distributive shock has? What is the difference which it has compared to the other types of shock? That I'll just explain. When it comes to septic shock, what happens? The system, mostly when it comes to septic shock, the system is getting attacked by multi-bacteria. A lot of bacteria, it releases its bacterial endotoxins, and it can lead to what happens? The peripheral vascular resistance is significantly decreased due to these toxins. So what happens when peripheral vascular resistance is getting decreased? Whenever the patient goes into shock, whenever the peripheral vascular resistance is getting decreased, afterload is decreased. So these cases, in a case of septic shock, the patient will have a high cardiac output, reduced systemic vascular resistance condition will be seen whenever there is a case of septic shock. I'll just explain once more that if at all 40 or 50-year-old middle-aged female or male presents with a case of infection. For example, if I tell you that the patient is had a erythema, pain and fever associated with the left lower limb, and you see that the patient has had a cellulitis for almost 3 days back, and now he presents to a casualty with acute worsening of pain with the associated formation of blood over his leg, and you notice that the patient is going into a state of necrotizing fasciitis. And on examination, you notice that his pulse rate is increased. The patient is having tachycardia. So BP is on the lower side. BP is on the lower side, and you notice that whenever the patient is having a pulse rate of almost 110, the BP will be almost 80/40. Just for namesake, I told, if at all the BP is 80/40, you notice something known as pulse pressure here. That is the difference between systolic and diastolic pressure. You notice that there is a wide pulse pressure in case of when you notice the BP. This is not a significant enough finding, we do not mention it, but if at all you notice it, you should keep in your mind that in the case of septic shock, diastolic pressure, which is significant, which signifies the systemic vascular resistance, will be decreased much more, signifying, and it can lead to a wide pulse pressure scenario when it comes to septic shock. And also you notice that the preload is not getting affected unless the system goes into a state of shock. Mostly the circulating volume decreases over time, can lead to hypotension. Before that, the cardiac output is not getting affected in septic shock. So it is a case of high cardiac output, decreased systemic vascular resistance condition in septic. That is what is happening in septic shock. Okay. Then what are the other things which can happen? What is the other scenario which you need to significantly notice is neurogenic shock. What happens in neurogenic shock? A neurogenic shock scenario is when a patient, for example, a diver from a height, a patient who dived into a pool, presents to a casualty, sustaining injury to the neck with painful neck. With the pain on moving your neck, you notice that the patient is having pain over his neck. And you notice that the patient, after gaining consciousness, he attributes that he cannot move both upper and lower limbs. And when you notice his BP and pulse, when you notice his hemodynamics, you notice that the patient is having bradycardia. Pulse rate is around 50s. And you notice that the BP is also on the lower side. What happens in such a scenario? Why does, even though the patient is in a state of reduced BP, or if the patient is in a state of hypotension, you notice that the pulse rate is not significantly increased. What happens when the spine is getting involved? As you can understand from what I told, when it comes to neurogenic shock, that is, in my case scenario, as I told, if the spine, or predominantly if the C-spine is getting involved, when a hyperextension injury is seen to involve the neck, what do you expect? We expect that the neurogenic pathways are getting affected. That is, sympathetic stimulation, which is supposed to bring about the tachycardia, is getting affected. So what happens associated with that? Even though the patient goes into a state of hypotension, it cannot be compensated by a state of tachycardia, which to compensate for the fall in BP. That is another entity, neurogenic shock associated with bradycardia and systemic hypotension. Okay. Then the fifth scenario, that is endocrine shock. When it comes to endocrine shock, there are three entities which you need to know about. Endocrine shock can be seen, basically it is a rare type. It can be seen associated with hypothyroidism, hyperthyroidism, and also Addisonian crisis. These three are rare entities. So I'll just give a brief idea. In hypothyroidism, mostly middle-aged female who was on irregular medication or stopped medications on her own, living on her own self, you notice that the patient is having significant lethargy, her reflexes are all diminished, and you notice significant hypothermia. That is a triad. That is altered mental status, hypothermia, and you notice that all the reflexes are all diminished in such a patient. When you see, you should always expect the patient to be in a state of mixed edema coma. That is hypothyroidism, untreated hypothyroidism. When it worsens significantly, that can present as a state of shock. That can present in association, that is, or in relation. The presentation will be similar to a state of neurogenic shock. That is, unlike, it won't present with tachycardia and hypotension. It presents with brady and hypotension. As I told you before, endocrine shock as an isolated picture, it does not have an isolated picture. It can be seen similar to a hypovolemia or distributive or an obstructive type of cardiogenic type of shock. Not obstructive, sorry. It can be seen associated or similar to a hypovolemic, cardiogenic, or a distributive type of shock. Similarly, in hyperthyroidism, what happens? Hyperthyroidism, it is thyrotoxicosis. That basically we know hyperthyroidism, tachycardia might be present. If at all, it goes into a case of thyrotoxic crisis. When does a patient go into thyrotoxic crisis? If a patient on medicines for hyperthyroidism is on irregular medications and he develops an etiology like a fever or an infection which can predispose to thyrotoxic crisis. Following such episodes, the patient can go into a case of thyrotoxic crisis, that is tachycardia, hypotension, that is a high cardiac output shock will be there. High cardiac output shock with reduced peripheral vascular resistance will be seen. Similarly, Addisonian crisis also is a very rare scenario, usually seen in patients who already have an autoimmune disease. Along with that, they might also have these conditions like congenital adrenal hyperplasia, which can be worsened whenever there is an etiology like a fever or an infection. So basically, we have discussed all the 5 types. I've told about the examples. Now we need to know, just learn how to compare all these 5 things using the 5 headings I told before. That is cardiac output, peripheral vascular resistance, venous pressure, mixed venous saturation, and base deficit. I just wrote about a basic idea. I hope everyone understands. Cardiac output, peripheral vascular resistance, venous pressure, that is mentioned by CVP, and mixed venous saturation, base deficit. What is mixed venous saturation? That is, in a case of shock, how much of the supply is getting utilized at the tissue level. That is basically to understand that oxygen supply minus the oxygen consumption is what can give you an idea about the mixed venous saturation. So whenever we discuss, I'll compare all the 5 types of all the 4 types. I told endocrine is a mix of all these. So whenever I'll compare all the 4 types along with these cardiovascular and metabolic characteristics. When it comes to hypovolemic shock, I told what happens, cardiac output will be decreased. When it comes to cardiogenic shock, I'll just write the headings first. Cardiogenic shock, then we have the obstructive shock, then we have the distributive shock. Okay. Hypovolemic shock, cardiac output is increased. Then as I told, when it comes to the cardiovascular system, compensate by sympathetic stimulation, increasing the peripheral vascular resistance. What happens in the venous pressure? In hypovolemic shock, I told you, the circulating volume is getting decreased. So what happens to the CVP? Preload, it is getting decreased. What happens to the mixed venous saturation? Mixed venous saturation means the oxygen supply and the oxygen intake. As we know, in a case of shock, the oxygen supply will be decreased and intake will be more. So mixed venous saturation will be low in case of hypovolemic shock. What is base deficit? Base deficit is basically, in a case of all these cases of shock, these are states of metabolic acidosis. Whenever there is metabolic acidosis, our bicarb levels will be decreased. How much of base is required to meet the demand, or how much base is needed to compensate for the deficit which has been created by the tissue, whatever issue is affecting our body. In all these cases of shock, base deficit will be decreased, as all of these will be presenting as a case of metabolic acidosis. When it comes to cardiogenic shock, similar scenario. Cardiac output will be decreased. Peripheral vascular resistance will be increased. When it comes to venous pressure, what happens? I told venous pressure is CVP, central venous pressure, that is measured usually in the subclavian or internal jugular vein, which are inflow tract into the heart. So, heart myocardial contractility is affected due to myocardial infarction. The preload is not getting affected. So, the venous pressure tries to compensate for that. So, what happens? Venous pressure will increase. Then what happens in mixed venous saturation? As I told, it will be low. Similar scenario to hypovolemic shock. Whenever the oxygen supply is decreased, intake will be more, so the difference will be decreased. Base deficit, as I told before, in all these cases, it will be a metabolic acidosis, it will be decreased. What happens in obstructive shock? As I told, cardiac output will be decreased. Cardiac output is decreased. What happens to the peripheral vascular resistance? Peripheral vascular resistance in obstructive shock is also increased. That is usual sympathetic stimulation. What happens to the venous pressure? Just like cardiogenic shock, we know that obstructive shock can tension pneumothorax. Obstructive shock, tension pneumothorax, cardiac time lane, pulmonary embolism. What happens? Right heart is getting compressed, or it goes into failure. So the inflow channels will try to compensate for that pressure. So always venous pressure will be increased when it comes to obstructive shock. What about the mixed venous saturation? Mixed venous saturation, as we know, even in obstructive shock, the outflow will be decreased. So mixed venous saturation will be decreased. When it comes to base deficit, it will be base deficit is always increased. In all these cases of shock, base deficit is increased. I made a mistake. That is, as per definition, I told, right? Base deficit is what? How much bicarb is needed to compensate for all these shock, all this metabolic acidosis, how much bicarb is needed, bicarb base is needed. So in all these shock, it will be metabolic acidosis, so base deficit will be increased. This is the next most important thing, is distributive shock. This is the most important thing which has difference compared to all other types of shock. As we know, as I told, distributive shock is associated with elevated cardiac output. That is a high output cardiac failure. This is a high output. Cardiac output will be increased when it comes to distributive shock. When it comes to peripheral vascular resistance, I told, in a case of neurogenic, or also in a case of anaphylactic, also in a case of septic shock, what happens to the peripheral vascular resistance? Peripheral vascular resistance will be decreased. Peripheral vascular resistance will be significantly decreased in all cases of distributive shock. What happens to the venous pressure? Venous pressure does not have much significance. It will be decreased because the circulating volume over a long time, because of the pooling, because peripheral vascular resistance decreases significantly, there will be venous pooling in the peripheries and capillary leakage leading to decreased circulating volume. So what happens to the venous pressure? Preload will decrease. Basically in distributive shock, preload will decrease. Mixed venous saturation. What happens to the mixed venous saturation? In distributive shock, what happens? Mixed venous saturation will be increased in case of distributive shock. What happens? Because it is a case of high cardiac output state. Cardiac output will be increased, and also I told oxygen supply is not getting hindered. What happens to the demand? Whenever the oxygen reaches the tissue, it won't be able to uptake. It won't be able to take up the oxygen due to the bacterial endotoxins or the other etiologies which are causing these issues. So this won't be affected. This will be affected significantly, that the demand will be there, but the oxygen cannot be consumed by the peripheral tissues due to bacterial endotoxins. So mixed venous saturation will be increased. And the last thing is base deficit. As I told, it's also a case of metabolic acidosis, so base deficit will be increased. This is a basic box showing the cardiovascular and metabolic characteristics of 4 types of shock, to differentiate between all these types of shock. With this, I think we'll conclude about this session, and all these topics should be dealt in detail to understand more about all these different types of topics. Thank you.